just roll right into to the next session. So on that note, we'll talk for the next 40 minutes or so about the incredible advancements that we've witnessed in transthyretin amyloidosis. Here are my disclosures. And here are our learning objectives. So we'll talk just a little bit about the subtypes and just remind ourselves about how we categorize transthyretin amyloidosis. We'll talk about the current standards of care for disease-modifying therapies and how we currently treat the disease, including indications and evaluation of response to therapy. We'll compare ATTR disease-modifying therapies that are currently in development and discuss what's coming down the pipe and describe their implications for long-term care strategies as these new agents come further along in development, and also how we implement strategies for symptom management for patients with cardiac amyloidosis in general. Okay, so I've already shown you this slide. I always like to come back to this when talking about transthyretin amyloidosis. It's the pathologic cascade for transthyretin amyloidosis and how it starts, what happens. So transthyretin is a transport protein, and its job is to transport thyroxine and retinol binding protein around in the circulation. So it's kind of like an Uber for the body. And it's made mostly in the liver. It's made in a couple areas, other areas as well, but most of it's made in the liver. And it's produced as this tetramer, this four-leaf clover protein structure. And the main problem that we see with transthyretin amyloidosis is that protein, that tetramer protein, dissociates, so it kind of dissolves into fragments, which are called monomers or dimers, and those fragments then begin to misfold and begin to stick together. And then they stack up and form these fibrils or these aggregates, these sticky clumps essentially that get lodged in certain tissues and cause the most damage to the heart and the peripheral nervous system. So there's two subtypes, of course, of transthyretin amyloidosis. There's the hereditary type, which is caused by a transthyretin gene mutation that's passed along in families, generation after generation. And this is relatively rare in Canada. There are a few endemic areas in the world, but it is the rarer form, certainly, of the two. And we know that it causes, again, predominantly cardiomyopathy or neuropathy, or as we're seeing more and more, a combination of those two things. Wild type is an age-related disorder. There's no gene mutation that occurs, so it's not passed along in families. And we know that this is the most common form of transthyretin amyloidosis that's diagnosed. In our clinic, we see probably 90% of the patients that with ATTR have the wild type version of it. And it predominantly causes cardiomyopathy or heart problems, although certainly it can affect the peripheral nervous system and other areas of the body as well. And so when it comes to the hereditary type, there's lots of gene mutations that have been identified over the years, and we're finding more and more all the time. This is just a handful of them listed on the top there, certainly not all of them. And we tend to categorize them based on the predominant system that they affect, so either neuropathy on the left or cardiomyopathy on the right. But as we're learning more and more, that patients often have a combination of the two. And one is typically more of a problem when they're first presenting and first diagnosed, so they'll have more of neuropathy or they'll have more of cardiomyopathy, or they may have only one of those two. But certainly that can evolve over time. and one system may become worse while the other stays relatively stable, or they can both progress together. So all kinds of varieties of presentations. But we know, and certainly from our clinic in Calgary, that most of our patients actually have unfortunately both systems involved. It's passed along in an autosomal dominant manner, and has, another way of saying that is, it's got very variable penetrance, the variety. Even within the same family, you can have very different presentations, very different clinical courses. Now, there's a few mutations that are relatively more common, and the ones that we generally know the most about and see the most. There's the Val30Met mutation. There's an early onset variety which affects mostly the nerves, and that affects mostly patients from Portuguese descent. And it is also called familial amyloid polyneuropathy. There's a later onset variant which causes more of a mixed presentation, neuropathy and cardiomyopathy, that we see in Scandinavian areas and Southeast Asian. And then there's the T80A mutation, which is predominantly an Irish mutation that also causes a mix. And then there's also the V142I, which is very prevalent, we believe, in patients of African Caribbean descent, and can cause a particularly aggressive cardiomyopathy, although we're seeing more and more neuropathy problems in that population as well. And then I threw the wild type in the middle there. We don't really know how common wild type is. We know it becomes more and more common with advancing age, but its actual disease prevalence we're not sure of. So lots of clinical manifestations. We know that the heart and the peripheral nervous system, so numbness and tingling, progressing on to problems with balance and muscle strength are the most common. But the disease does affect other areas as well. And so what can tip us off to look for it? Well, if a disease is progressing with more and more systems being involved, that is often a tip-off that this might be amyloidosis. I've listed some of those other manifestations here. Of course, carpal tunnel syndrome is exceptionally common with all types of ATTR. Most of our patients have had it in the past or will go on to get it. We see other systems of the nervous system involved, including the autonomic or automatic nervous system of the body, which controls things like blood pressure and heart rate, also controls bowel and digestion, as well as the bladder, sexual function. All of these things can be affected by amyloidosis, progressive weight loss, and even some ocular manifestations can happen with some of the hereditary types. And so if you see a combination of these things, that should really tip people off that maybe they have amyloidosis. If there's a family history, that's helpful, but of course we didn't know much about this disease in prior generations, and so often, even though there is a family history, we didn't know about that family history until we're meeting our patients for the first time. But these are some of the manifestations that we look for nowadays when we're trying to diagnose it. And so for transthyretin amyloidosis, we used to really just, as I mentioned in our last session, we used to have just one pathway for management, essentially, except for the odd patient who was eligible for liver transplant. But really, we were left just controlling their symptoms, and often that meant water pills and diuretics to manage fluid retention, and a few other medicines to manage, heart rhythm problems that may arise. But nowadays, fortunately, we have a second parallel pathway of management for these patients, and that's disease-modifying therapies that alter the trajectory of the disease's progression, fortunately. So on the bottom there, as I mentioned in the last session, are the two current categories of treatment for transthyretin amyloidosis. We have gene silencers, and these are currently approved for only the hereditary type and only for the treatment of neuropathy symptoms, so hATTR polyneuropathy. And there's been two agents that have been available for a number of years. inotersen and patisiran, and they both drop production of the transthyretin protein at the level of the liver. Inotersen is unfortunately no longer available in Canada. However, two new agents have come along and recently been approved, next generation silencers, vutrisiran and eplontersen, both currently approved for hereditary ATTR polyneuropathy as well. And then the other category is TTR stabilizers. These bind to the TTR protein and prevent it from dissociating or disintegrating to prevent further amyloidosis buildup. There's currently one drug approved in this category, tafamidis, and that's approved for patients with both types, hereditary and wild-type ATTR cardiomyopathy, so that's a cardiology drug. So I'll go through these agents a little more closely just to describe the current state of treatment for disease-modifying therapies for ATTR, and then we'll move on to talk about what's new and coming. So tafamidis has been around in Canada since 2020 and is used now quite frequently, fortunately. Very effective drug. It's approved for patients with functional class 1 to 3 symptoms for either subtype, as I mentioned. And we know from the pivotal study, the ATTRACT study that came out, that its benefit is the most in patients with earlier stage disease, and that's generally true for most diseases like amyloidosis that are infiltrative. It's once daily dosing. It's very easy medication to use. There's virtually no side effects or interactions. And again, it prevents disease progression. So often the important message when we're starting patients on it is that you're not going to feel better on this medication, at least not for a while. It's really designed to prevent the disease from getting worse. Now that tafamidis has been around for a little while, we've learned a lot more about its use and how patients respond to it over the longer run. And so there was the initial clinical trial that proved tafamidis works, and then there was the subsequent extension of that trial, or open label extension, where patients were put on the medication for a longer period of time, and we were able to chart their progress and how they did. And that also included patients who were on placebo for the original ATTRACT trial. And what this showed is that the patients, particularly those on placebo, which was the most interesting, had a leveling off, as you see kind of towards the end on the blue curve there, of the adverse events and mortality once they were put on the drug. Now, those patients were generally worse off than the ones who were on the drug during the trial, of course. And so when they were put on the tafamidis for the extension, they were at a much later stage of the disease, unfortunately. But what this essentially showed is that even for patients who are at a later stage, there is likely benefits to being on tafamidis and treatment. The benefit is, of course, the greatest when you diagnose it early and start treatment earlier, but there is still some benefit even in later stages of disease. And it might be hard to see, but there's kind of a dotted line there. That's kind of a projected decline in survival for patients in the placebo group who were not treated with the disorder, not treated with tafamidis. So that's not real data. That's just a projected what their trajectory would be had they remained off treatment. And so we have next generation stabilizer as well. And this is an exciting development. So we have acoramidis, which that trial, the ATTRibute trial, has concluded, and the results have been published, and it was a positive study. And so this is a medication that works in a similar way to tafamidis, although not quite the same approach, but it does try to stabilize the TTR molecule, and actually mimics a mutation that is protective or stabilizing of that protein. And so the attribute study wrapped up and was demonstrated to be a positive trial. And you see the disease characteristics here of the baseline characteristics here of the patients who were included in the ATTR, in the attribute study. Similar to the ATTRACT study, a little bit older patient population, and a little bit earlier in their disease course, because it was a study that was conducted a bit later, and we had already learned more about diagnosing the disease, so we were able to diagnose and detect patients at an earlier stage. The ATTRACT study was actually conducted before PYP was the standard of care for diagnosing ATTR. This study as well was a cardiomyopathy study. So all patients needed to have cardiomyopathy, and patients were also allowed to be on tafamidis after being in the study for 12 months. And this study was positive, as I mentioned, and there was a survival benefit. And acoramidis's claim to fame, as you see there on the left, is that it is a superior stabilizer, so it effectively stabilizes more of the ATTR molecule compared to tafamidis, as you see. So it's not yet available in Canada. We're hoping that it will become available within the next year or so. It's also once daily oral dosing, and also very similar in that it's well tolerated with minimal to no side effects and no drug interactions. So moving back to our silencers, which are currently approved, and these both work by reducing, as I mentioned, ATTR or TTR production at the level of the liver. There's inotersen, which, as I mentioned, is unfortunately no longer available in Canada. It worked as an antisense oligonucleotide mechanism, and it was injected subcutaneously once weekly. And the main caveat with inotersen is that we had to monitor patients' platelets, because they could drop and put them at risk for bleeding if there was a significant drop. Similarly, both of these agents, inotersen and patisiran, also attenuate disease progression, so there is a halting of worsening of their neuropathy symptoms. And then patisiran, which is used quite commonly now, is an IV infusion that's given every 3 weeks. Its mechanism is a small interfering microRNA. Works in a similar manner in dropping ATTR production and attenuates ATTR neuropathy progression. So we'll talk about this a little later in the day in the session, but often what gets raised is how effective are these drugs for the symptoms that they are not indicated for. So how effective is tafamidis for neuropathy? Tafamidis has been used for hereditary ATTR neuropathy for many years in Europe, but is not approved in Canada. The silencers are approved in Canada, and they're approved for the neuropathy, but are they of any value for the heart? Do they protect the heart? And so this was a sub-study of the Apollo A, which was the neuropathy trial that proved that patisiran worked. And for this sub-study, they looked at patients with presumed heart involvement by echocardiogram to see if their hearts were thick. They didn't have PYP for this study, so they couldn't confirm it. But these were patients with suspected cardiac involvement. And they looked at their outcomes, hospitalization and mortality, and they saw that there was indeed a benefit. Now, small patient numbers here, but there was indeed a benefit for patients who were on ATTR, who were on patisiran. And that led to the Apollo B study, which was a cardiac-focused study. So these are patients with ATTR cardiomyopathy. And this was a 1-year study, and the primary endpoint was a 6-minute walk test. And so what this study showed was that there was indeed attenuation of decline of 6-minute walk test. So similar to the neuropathy results, it attenuated decline. Patients didn't improve, but they didn't worsen as quickly as if they were on placebo. And so this was a positive study, but there's a bit of a story here. Unfortunately, the drug was not approved in the US and has therefore not been applied for in Canada for the treatment of ATTR cardiomyopathy. Unfortunately, the FDA reviewed it and still wasn't convinced. And so patients with cardiomyopathy can't get access to patisiran, and it's only available for those with neuropathy. Now, I mentioned that there's now 2 new approved agents, next-generation silencers. This is the eplontersen is next-generation inotersen. They've managed to correct that problem with the platelets, unfortunately, and so this medication is much better tolerated. It's given as a subcutaneous injection monthly, and the NeuroTransform study was the study that showed that it worked in hereditary ATTR polyneuropathy. And this demonstrated that it was well tolerated. Whoops. And I'll show you the results in a minute, but essentially attenuated further disease progression, very similar to inotersen, but without the concern about platelet lowering, and so a much better tolerated therapy. Around the same time was the HELIOS-A study, which is for vutrisiran, which is next-generation patisiran. Rather than being given by IV infusion, it's now given by subcutaneous injection, so much easier, and it's only given every 3 months, in fact. So it's, in that way, it's almost like a kind of a vaccine. You just kind of have boosters every 3 months to lower production of ATTR. And both of these studies, again, demonstrated similar results to their prior generation predecessors. They attenuated disease progression of neuropathy very effectively. And both of them have cardiac data that's been collected or being collected to see how well they work for cardiomyopathy patients. But we're very happy that both of these drugs are now approved in Canada. So again, does it work for the heart? You know, the question from the neuropathy study for eplontersen. And this shows, again, in a sub-study analysis that, and most of this is imaging echo data, that, again, there is a suggestion of benefit and that patients who are on eplontersen had general better cardiac measures than patients who were not in the NeuroTransform study. But there is the CardioTransform study that's still ongoing. So this is actually the largest ATTR clinical trial that's been conducted. And it has been going for a number of years. We have a number of patients in Calgary and a number of others across Canada who are still participating in CardioTransform to investigate the benefits and effects of eplontersen in patients with ATTR cardiomyopathy. We think this study will be closing in the coming months, but it's still an active study at the moment, and we'll be eagerly awaiting the results to hopefully confirm its benefits in a cardiac population. But for vutrisiran, actually, we don't have to wait any longer. We have that data. This was announced at the European Society of Cardiology meeting in London in August, that HELIOS-B was a positive study, and patients lived longer and had fewer hospitalizations when they were treated with vutrisiran for cardiac involvement of ATTR. Again, all of these cardiac studies include both hereditary and wild-type patients, so very exciting news. I think one of the main discussion points that came out of the HELIOS-B study is that quite a few patients were on tafamidis as well as the standard of care for patients with ATTR cardiomyopathy. And so the question becomes, is there a benefit to dual therapy versus not? Now, the study was not designed to answer that question. Certainly there was a suggestion of benefit, But the extent of that benefit is still up for debate. And of course, whether that degree of benefit can justify, the costs of being on 2 versus 1 very expensive therapies, I think will be debated for quite some time. But the bottom line is that we're kind of very excited to kind of finally have gene silencer data that benefits a cardiac population from a clinical trial. Again, it's not yet approved in Canada for cardiac patients. We hope that's coming. It's only approved for neuropathy patients. But we will expect that we can treat our cardiac patients as well. And this just kind of shows that there's benefits in patients with earlier disease stage, as you might expect. And of course, those patients who are also on tafamidis had some benefit, although the magnitude and the significance of that is still being discussed and considered. But of course, there's new categories of drugs coming down the pipeline as well. So not just new agents, but new categories. So there's depleters, which serve to reduce the amyloid burden inside the heart. And they are monoclonal antibodies. So they're essentially antibodies that attach to amyloid deposits and act like homing beacons for the immune system, whereby the immune system can then find them and through phagocytosis break down those amyloid deposits. So very exciting. There's 2 agents that are currently being investigated. There's one clinical trial that's starting up in Canada called Depleter, and there's another one called Cleopatra, which will be starting next year for phase 3 trials for 2 new depleter agents. And initial data is very encouraging from phase 2 studies to suggest that there's improvement in amyloid deposits in the heart as assessed both by PYP scintigraphy, as you see on the top right there, as well as cardiac MRIs. So there's a lot of hope for these drugs. The trials will take a couple years, so they won't be available imminently, but a lot of buzz and excitement with regards to this new class of drugs. And of course, there's even more not to be outdone. Now we have CRISPR-Cas9 study also being starting up right now in a few sites in Canada. And this is gene editing. And so what this is essentially like a one-time gene silencer. So you get a one-time infusion and it knocks out most of the TTR production that your body makes by snipping out the gene that makes it. And then you essentially would have kind of lifelong disease attenuation and stop making the destructive protein. This is the magnitude study, which is getting underway, as I mentioned, in a few sites, and so a lot of excitement with regards to this class of drug in general. It's not just an ATTR drug. It's being tried in a lot of different diseases, but in many ways, ATTR is kind of an ideal type of disease to use CRISPR technology in, and so we're very excited about this as well. So to kind of gaze into the crystal ball of the future, if all of these trials are completed and positive the way we hope, what could the treatment landscape look like? Well, we don't really do liver transplant anymore now that we have all of these exciting therapies. There's only a few places that are still doing them. We have new gene silencers and new indications for gene silencers. We have now a new stabilizer, so 2 stabilizers, and we also have 2 new classes of drugs. We have CRISPR-Cas9, which shuts down production of the TTR protein, and we have the depleters, which help to take away amyloid deposits in the heart and the nerves and other tissues. So very excited and ever-growing and crowded treatment landscape. And so with all of this research going on and all of these clinical trials and all this work being done, how is this going to affect the standard of care? How are we going to be using all of these drugs? Are we going to be using them in combination? Are we going to be using them in sequence? And if so, how? So lots of questions. For patients, the current approach is if you have cardiac involvement, you go on tafamidis. If you have hereditary neuropathy, then you're treated with a silencer. We have monotherapy, but likely this is going to change. And of course, who's going to pay for all of this, right? These drugs are all expensive, and so that will play an important role in how they're prescribed across Canada. So lots of knowledge gaps, and of course, we've focused a lot in recent years on improving our diagnosis rates, which have gone up, and getting patients on treatment as early as possible to stop the progression of the disease as soon as we can. We know that's the best strategy, but it doesn't end there, right? We now monitor the patients, see how they respond, see if their disease progresses or if it even reverses. Or stays the same year after year once they're on treatment. How do we do that monitoring? What are we looking for? And how do we respond to those changes, especially if we have more and more options with drugs to use? All of these remain important questions that are essentially unanswered. Lots of theories and lots of ideas, but we need more information and more data to really help guide us. And then, of course, there's also the population of patients who carry a mutation but have not yet developed the disease, the asymptomatic gene carriers. And what do we do with them? How often do we monitor them? When do we start treatment? These are all questions that we're struggling to find the answers for and need more information. So there's lots of approaches out there that are suggested for how to monitor patients. This is one that came out a few years ago, which I quite like, which is kind of very clinical and practical. It's looking for new manifestations of the disease or new functional disabilities or changing of one of their parameters to try to define disease progression. It's a practical approach, and often these things kind of look very nice in figures, but can be challenging when you're actually sitting across from a patient and you're trying to figure out exactly, what is going on with them and why. There's been more specific recommendations incorporating different tests that we use. This was a cardiac one that was recommended a few years ago, which gave some recommendations on what tests to do and how often to do them, and then what to look for. These are all very sensible, but are not really evidence-based, and so they're kind of expert opinion-based, which is helpful, but as, again, more drugs become available, I think we need more evidence and more tools to refine these. Here's a more recent one that just came out earlier this year, which tries to simplify defining disease progression, and this is specific to cardiac patients, looking at their NT-proBNP and their diuretic dose as the two main parameters used to define disease progression. And so if their NT-proBNP goes up or their diuretic dose goes up, then that satisfies a criteria for disease progression, and it correlates very nicely with survival and outcomes. And so, there are lots of prospective tools being used. Again, we're still looking for how best to use them, and if we find progression, how do we respond to it? Coming back to the question about asymptomatic gene carriers, there's a study that's starting up shortly that's very exciting called ACT Early, which will enroll asymptomatic gene carriers and randomize them to either acoramidis, the new TTR stabilizer, versus placebo, and to see if putting asymptomatic gene carriers on preventative treatment prior to the disease initiation and prior to the symptom onset is helpful in preventing disease. So this is also a very exciting study. It's going to take many years, of course, because these are asymptomatic patients, and so what they're looking for is progression of the disease. But it's starting up and is really quite revolutionary in the ATTR disease space, kind of a treatment aimed potentially at asymptomatic gene carriers. And so, and I think I have a couple more slides and then we'll wrap up, but we focused a lot on disease-modifying therapies, and we haven't really talked too much about advancements in controlling complications of disease like heart failure and fluid retention and rhythm problems. We are making progress in that area too, and so the left side of this parallel pathway, controlling complications. And so one drug that's being used now quite commonly in other cardiovascular and heart failure populations is sodium glucose transport type 2 inhibitors, or SGLT2 inhibitors, and they're proving to be almost wonder drugs in the cardiovascular disease space, especially for patients with heart failure. These were initially designed as diabetes drugs to treat high blood sugar, and almost accidentally were found to have quite a profound cardiovascular impact by enhancing excretion through the urine of sodium and glucose. And so they work so well for other types of heart failure. Do they work for amyloidosis as well, and transthyretin amyloidosis? And there was a study that came out again earlier this year from the UK and Italy looking at patients who were treated with these drugs. And they found that generally, yes, they did live longer. They had fewer hospitalizations. This wasn't a randomized controlled study, so it has some limitations. It was a retrospective study. But these drugs are very well tolerated for our amyloid patients, which is not true for other cardiovascular medications, as we know. And so I wouldn't go so far as to say they're the standard of care yet, but certainly they're being used quite a lot. And certainly for patients with ATTR and heart failure, they're being used quite a bit. They're well tolerated, and we think there is a very important effect with minimal, if any, side effects. And so you've kind of sat through a whirlwind tour of advancements in ATTR, so congratulations. As mentioned, our current standard of care with tafamidis for cardiomyopathy patients, silencers for hereditary ATTR polyneuropathy patients, but new therapies, new indications, and new classes of therapies are on the way. And my hope over time is that some of the distinctions that we've used for indications, such as hereditary versus wild type, cardiomyopathy versus neuropathy, will begin to blur and almost fade away, and we'll treat ATTR as one disease that has many faces and different causes, but still a systemic disease. And that these treatments work really well for all types, regardless of your manifestations or presentation. New approaches for disease monitoring, I think these need to be further refined, but we're making progress there. And of course, all of this advancement leads to many questions: combination therapy, and how long to be on one therapy, do we change, when do we change, all of these things yet to be answered. And of course, asymptomatic gene carriers in the ACT Early study, will that be positive? Will there be benefit there? And continuing to refine how we look after the complications of disease. I'm a cardiologist, so I've talked about the heart a bit, but we're making lots of headway on neuropathy as well. So thanks for listening through all of that. And I'm not sure if we have time for questions or not. We do? Okay, yeah. I'm getting the thumbs up from Alon, so. Any questions or comments from anyone? Yeah, hi, Gordon.
So I have a question. You shared your experience about the use of combined silencer and stabilizer in patients who have mixed disease. I try to do that, but it's not possible because of the coverage. Because
Yes.
the patient support program would not accept if they have the other treatment. So I think it's a good approach, but it's not practical because it's not covered.
Yeah, no, that's an important comment. So, and if you missed the first part, so that's combination therapy for ATTR. You know, currently there are patients who might technically have indications for both. So they may have hereditary patients who have both cardiomyopathy and polyneuropathy could theoretically be treated with tafamidis and one of the silencers. However, public coverage and even private coverage is not available for those patients. So doesn't really exist in Canada. And I would be surprised if it's something that exists in the near future, even with all of this advancement and these new therapies, just simply based on the cost. And we've seen this, you know, with other rare diseases with expensive therapies where combination therapy could theoretically be done, but the benefit is not high enough to justify the cost in the eyes of payers, and so it's only single therapy. Now, it is being done in the United States with their interesting insurance system. Some patients do have coverage for both. We don't have really any good data on that just yet, and the benefit is not clear. I think over time, we may see some randomized trials with regards to combination therapy, but I think that's many years off. So, you know, important point, it's not an option kind of period in Canada, and most of the world, and likely will not be for the foreseeable future. Michelle.
Really tricky ethically for these people who are on the cardio transform, like they're already looked at.
True. Yes. Yeah. Yeah. So great comment. And in case you didn't hear, the comment was that, so for some of these, well, not some, for the clinical trials that are currently active, including CardioTransform, which is looking at eplontersen for cardiac outcomes, those patients, majority of them, like HELIOS-B, as well, are already on tafamidis because that's the standard of care. So it's, you know, you can't deny someone that care. So those patients are essentially on dual therapy if they're randomized to the drug. Likely what will happen, and we see with many of these trials, is that, as we've seen with the other ones earlier, is that there's an open label extension study, so the trial closes, and then the patients, whether they were on placebo or the drug, are provided the real drug provided by the company free of charge for a number of years to study the ongoing effects of being on it. So those patients can remain on dual therapy until that open label extension study concludes. And so then what happens, right? You know, they've been on dual therapy for a few years, and then if their coverage is not there, which we don't expect, then one of those drugs is pulled away. You know, that has ethical implications, as Dr. Meze has pointed out, and opens up a whole host of other questions about optimal treatment. So which drug do they stay on if they're eligible for both, right? It's going to be very challenging, I think, to answer some of those questions. And, you know, this is kind of the interesting paradigm that we're in, whereby we've got one disease with different manifestations and faces, and then as a result, different indications. Somewhat artificial in my mind, but it's created a lot of dilemmas that we're going to be dealing with for years to come with regards to treatment decisions. Coverage is similar but not the same from province to province, and criteria are not identical, so that will play a role as well. So lots of questions that are unresolved that we're going to have to work through over the years. Okay, a few questions here.
Dr. Fine, we have a question virtually that we'd like to...
Oh, okay, yeah.
Okay. Is there any research looking at prescribing levothyroxine to stabilize the tetramer, especially in patients with a history of fluctuating T4 levels?
That's a great question, and so just to take a step back, you know, we know that TTR transports thyroxine, you know, thyroid hormone through the circulation. And as a general statement, you know, we haven't seen a lot of adverse effects for the thyroid from having TTR, or ATTR, pardon me, or from the treatment for ATTR. So thyroxine is transported by TTR, but it can also get around on its own. So, you know, it can walk as opposed to taking a cab or an Uber. And it has other transport mechanisms. And so, in general, we haven't seen significant adverse effects of the thyroid from either the disease or its treatment. Now, we know the other protein that's transported by TTR, of course, is retinol-binding protein and a vitamin A. And so that's not the case for vitamin A. So patients do need to go on vitamin A supplementation if they're on one of the silencers. And similarly, for the CRISPR study, if they'll need to be on vitamin A supplementation for the rest of their lives. So the question was, you know, for patients who may have adverse thyroid effects, is there research being done? Not that I know of. There may be some research going on that others in the audience are aware of, but I don't know of any kind of major research studies or ongoing trials that are looking at thyroid-related outcomes in this population. And in general, we haven't seen a lot of thyroid problems either. You know, a lot of our patients will have concurrent hypothyroidism, particularly if they're older. But we tend not to think that it's a disease complication. We had a few other questions, I think. Oh, there's a question here, yeah.
How much vitamin A should I be taking?
Yeah, generally it's 2,000 units, and that comes with the product monograph. So if you're on one of the silencers, it's a standard dose of vitamin A. Kind of an interesting caveat to that is that the silencers kind of interfere with the essentially the testing results. So we actually don't test vitamin A levels, and we don't adjust the vitamin A supplementation. We just put patients on vitamin A supplementation, and generally they do very well. And we haven't, as long as they're taking the vitamin A regularly, we haven't seen any ocular eye problems, fortunately, with the silencers. So that part seems to be pretty straightforward, we think. Yeah.
It was 2,000.
Yes. Yeah, I believe it's 2,000. I'd have to double check to see if it changes from the monograph. 3, pardon me, 3. Yeah, 3,000.
Can't get that, so ours we can only get 10,000 for the dose, so we tell them to take it twice a week.
Yeah, thanks for correcting me. Sorry, it was 3,000. And Dr. Meze was just pointing out that that can be an awkward dose to prescribe. It's not always carried in that formulation and dose in some pharmacies, and so we try to kind of mix and match what's available to achieve that 3,000 units a day dose. Thanks, and thanks, Jean-Pierre.
Question here. So a broader question of, it's often referred, ATTR is a disease of the elderly, but isn't it just discovered when you get older, and isn't it a disease much earlier, often much earlier in life?
Yeah, that's a great question. Yeah.
And so it's confusing to me that, you know, it's described as a disease of the elderly.
Yeah. When does it really start, right? The truth is, we don't really know. For wild-type patients, it generally progresses very slowly. For hereditary patients, often it progresses much quicker. But when does it start, and when does the buildup actually happen, and when does that buildup begin to cause organ dysfunction, whether it's in the heart or the nerves? We don't know the answer to those things. We certainly know we diagnose it, as you say, mostly in older patients, and in North America, at least, even our hereditary population tends to be over 60 when we diagnose it. But when do the manifestations start? We tend to think that carpal tunnel syndrome is one of the earliest or earlier manifestations of the disease. And so lots of discussion about how best would we screen patients with carpal tunnel syndrome, but it's an incredibly common disorder. And so screening everybody is simply not practical. But yeah, it does remain an unanswered question, and I think particularly for asymptomatic gene carriers, kind of figuring out when the amyloid deposits are building up and at what point do you intervene is really a critical unanswered question. Thank you. Ryan?
Hi, Noel. Great talk. Thanks for that. Maybe it's more of a comment than a question, but I think one of the things I was struck by that I struggle with patients, hereditary patients, and their families is, I think many of them come to me saying, when do my family members go on treatment? I don't want them to get to the point that I'm having symptoms, and I know that the medications at this point don't reverse symptoms. And this is why it's more of a question, because we know, unfortunately, we can't get coverage until there's some degree of polyneuropathy or cardiomyopathy.
Right.
But I just want to say that it's something that I struggle with, and I'm sure that it's something that the patients that are here in the audience, I know that them and their family members, I'm sure, struggle with that. I don't know if you have any comment on that.
Yeah, it's a great point. It's an important point, and it's an area that we all struggle with, the entire field around the world, and we need better information to help guide us on this. There are some, I guess, theories or approaches, and this is something that Dr. Meze and I will touch on at our symposium at the end of the day. And there's the concept of predicted age of disease onset, or PADO, right? To try to use what you know about the patient's family history and what's happened in their family, try to use what you know about the gene mutation itself and the disease itself to try to guess when the disease is actually going to happen in an asymptomatic carrier, and therefore when is the right time to start monitoring them, and then what are you looking for and how often do you monitor them. But those are all educated guesses, right? Which is kind of unsatisfying when we're talking about a potentially fatal disease, right, and a crippling disease in many ways. So it's an important point. Hopefully we'll learn a lot more with things like the registries and studies like ACT Early to try to understand that better. We rely heavily on genetic counselors as well to help coach families, and that's just for monitoring, right? That's not even answering the question about when should a potentially at-risk person get genetic testing done, right? A lot of personal elements to that as well. So great comment. We do our best, but it's a struggle for everybody involved, and hopefully that will get easier and we'll have better processes in the future for that.
Building off of that last comment, I'm thinking about the tools that are available for patients and caregivers when they're having these conversations with their specialists.
Yes.
The last slide was a helpful one to summarize the treatments available. I'm wondering what's being done to further that education so that when the patients and caregivers are having those conversations, they're aware, one, of the options that are available and ensuring that their specialists know which options are available, as well as understanding the decision point of, if I'm going down this pathway, that may exclude me from this pathway in the future, given the fact that some of the symptoms may present themselves at different times and potential severities.
Yeah, it's a great question, of course, very important as well, with kind of lots of pieces of that puzzle, right, when it comes to answering that question and having those conversations and making those decisions that are involved. I mean, there's a few elements to that. I mean, generally, part of that comes down to availability and access of amyloidosis specialized clinics. Does a person have physicians and clinics that are available in their area to try to answer that question? We tend to work together with our genetics counselors to come up with a unified recommendation. Of course, that depends on access to genetic counselors, which is also quite variable. I think probably the best answer I can give you is that we continue to work on it, right? In the sense that, Transthyretin Amyloidosis Canada is an important resource for patients and their families to try to gain information about their disease. One of the major goals of the society that we'll be talking about further tomorrow is also to try to work on the multidisciplinary care model for amyloidosis patients and their families to try to improve access to clinical advice and recommendations and decision making. So I don't have a kind of a single answer for you. I wish I did. But I think this was kind of what I was talking about earlier, is that we need to kind of progress the resources that are available to support patients and their families, because these are difficult decisions, and there's not kind of one single right answer. The decision comes down to a lot of individualized factors, right? A lot of personal factors, both with regards to the family history and the disease itself. And so you really need personalized, individualized care when deciding, okay, when are we going to do genetic testing on at-risk family members? How are we going to monitor them further? So that's the best answer I can give you in 2024, but hopefully we'll continue to improve upon access and then that process, yeah.
We have time for one more question. Thank you, Dr.
Okay,
Flynn.
great. Thank you very much. I appreciate you listening.